Very good morning to all of you. This is the third and the concluding part of this three-part lecture on radiographic interpretation of diseases. So, the learning outcomes would be similar to what we have seen, and in this part of the lecture series we are going to cover the third topic, the third point, that is identify and describe radiographic characteristics of malignancies, systemic diseases and bone diseases affecting the jaws. Let's look at some fibro-osseous lesions, which are one of the common bone diseases that affect the jaws. When you think of fibro-osseous lesions, obviously some very common lesions that we know come to our mind. So look at this picture here. This is a clinical photograph of maybe a young patient, looks like an adolescent who is probably around 9 or 10-year-old, and you can see that if this is the midline, then both sides of the jaw are not having the similar kind of appearance. You'll see that the right side is slightly enlarged in comparison to the left side, and the vestibule on the right side is obliterated. So when you're looking at this, you will think of obviously a bony expansion, either a cyst or a tumor, but when you actually take a radiograph, it has this orange peel-like appearance, and it can mimic what is called as looks like fibrous dysplasia. Okay, so this appearance of trabeculae, which changes and appears dotted and doesn't look very wide and like the usual trabecular pattern, is called as orange peel appearance. So in the mandibular occlusal view here, you will notice that there is expansion. The white arrow mark is pointing towards buccolingual expansion of the bowl. Similarly, in the mandibular molar image that you are seeing here, you can very clearly demarcate that in the furcation of the mandibular first molar, you're seeing that the marrow spaces are wider, and that is normal bone, whereas from the distal root of the first molar onwards, extending towards the 7 and the 8, the trabecular pattern has changed. It is looking very dotted and smaller in size, and what we typically call as orange peel appearance. Similarly, on the maxillary occlusal view that you're seeing here also, there is a lot of a thickness of bone and mixed radio-opaque radiolucent appearance, giving the appearance of what is called as orange peel appearance. The fibrous dysplasia can also mimic a ground glass appearance, where there is enlargement, which is seen here on the skull CT image, and then you are able to see on this PNS view that there is enlarged maxillary sinus, and looks like the lesion has originated from the maxillary sinus area or the maxillary bone, and then there is enlargement and complete obliteration of the sinus area, which is looking very dense and similar to what is called as ground glass like appearance. So there's change in the bone here, and which appearing more denser than the usual bone if you can look at it, compare it on the other side. From your knowledge of pathology, you are aware that fibrous dysplasia is either monoostotic or polyostotic. So if both sides of the maxilla is also involved, it is called as polyostotic, because maxilla comprises of two bones which are fused in the center, whereas mandible is a single bone. This is another appearance of fibrous dysplasia appearing on both sides of the mandibular bone. There are arrow marks pointing towards the mandibular body region, where the appearance looks very confusing, but the trabecular pattern is not normal, and this is what is called as ground glass, or also called as fingerprint like appearance. So orange peel, ground glass, fingerprint are all terminology used to describe the radiographic appearance of fibrous dysplasia. Next, we move on to periapical cemental dysplasia. Now, I'm not discussing the treatment and the the clinical features of these diseases. Reason being, it's assumed that you have already having a basic background of all of these diseases. I'm sure fibrous dysplasia was extensively covered in oral pathology, and that's the reason why I'm only touching upon these diseases from a radiology point of view. And if you do need clarification, you might have to look up the radiology textbook, which gives you very beautifully detailed uh, details about the disease. And you could also cross-refer with oral pathology textbook. On oral medicine textbook, on the other hand, gives you lesser information because these are primarily bone disease. Yes, so coming to periapical cemental dysplasia, also short form of PCD. Now this, from what we've learned earlier, is a disease which progresses from early stage to a late stage. So hence we are showing you stage 1, stage 2 and stage 3 here, and that's the appearance. Classically you will see that the disease starts off as radiolucency near the apices of the teeth. One of the favorite areas is the mandibular anterior region. So when you think of periapical cemental dysplasia, the image that should come into your mind is this radiographic image. Just like in fibrous dysplasia, the first thing that should come to your mind is a maxillary lesion. Lesion involving the maxilla. Periapical cemental dysplasia predilection is generally mandibular anterior region. So here in this radiograph you can see that the stage 1, it appears radiolucent, stage 2 is mixed radiopaque radiolucent, and stage 3 looks more radiopaque. So if you notice, the disease as it is aging is becoming more and more radiopaque. Now one thing to remember here is that how soon will the patient go from stage 1 to stage 3 is very difficult to tell, and sometimes it could even take a long time, like for example 10 years for the patient to progress from stage 1 to stage 3. A very important point to remember here is that in PCD the teeth are vital. This is a problem with the cementum. The unregulated cementum is laid down, excessive amount of cementum, and on radiograph, since cementum looks very close in density to bone and dentine, it's very difficult to make out exactly where the lesion is, and the density looks very similar to that of bone. So if you observe in stage 1, it is completely radiolucent and can easily mimic a periapical rarefying osteitis or a periapical abscess. So you could get confused. So when you look at a picture like this, you will obviously do the vitality testing for the teeth, and if the teeth are vital, then you know what you're looking at. Stage 2, it can look as condensing osteitis. That is what is the differential diagnosis given here. It still has a mixed radiolucent radiopaque appearance. So again, vitality of the teeth, checking the vitality is very important here. Stage 3 is more dense, and the cementoma, cementoblastoma, or an odontome, even an odontome appearing at the apex of the tooth, could be thought of as a differential diagnosis, radiology differential diagnosis. And what you classically see here, which is written in yellow here, is there's a radiolucent periphery around the rim, like a peripheral radiolucency which is seen, which is very similar to cementoblastoma as well, like we had discussed in the last class. So this is periapical cemental dysplasia. Same disease but different region. The terminology that is used is focal cemento-osseous dysplasia. Now generally when we're talking about focal cemento-osseous dysplasia, the image that should come to your mind should be the radiograph of a mandibular molar region with dense radiopaque like area at the apex of the tooth. Again, the radiolucency could be, the lesion could be a mixed radiopaque radiolucent lesion depending on the stage at which you're looking at the disease. So the differential diagnosis is benign cementoblastoma or dense bony islands. Florid cemento-osseous dysplasia. This is again the same form of the disease. Periapical cemental dysplasia, focal cemento-osseous dysplasia, florid cemento-osseous dysplasia are all same disease but manifesting in different parts in the jaw, and the extent of the disease is also different. So when you're talking about periapical cemental dysplasia, we're talking about mandible anteriors. When we're talking about focal cemento-osseous dysplasia, we're generally talking about one or two molars involved in one or two areas. And when you're talking about florid, it's more generalized. So in this panoramic view that you're seeing here, you will see that both maxilla and mandible have these unexplained radio opacity surrounded by radiolucent and a mixed radio-opaque radiolucent image seen. So the differential diagnosis would be gigantiform cementoma, familial multiple cementomas. The other names for this disease is Gigantiform cementoma, familial multiple cementomas, and differential diagnosis is Paget's disease, chronic sclerosing osteomyelitis. Yes, moving on, cemento-osseous fibroma, ossifying fibroma, and cementifying fibroma. Now, this is again, all of these are nearly the same disease that is having different names. So when you're talking about ossifying fibroma, which is a more accepted name, this disease could be both radiolucent and radio-opaque or mixed. So you can start off as a large radiolucency near the mandibular molar region, or could be a mixed radiolucent radio-opaque lesion. Sometimes you can even see septae like the image that you're seeing here. This is an occlusal view of the mandible, and that's a cropped oblique view, where you can see that there is enlargement of the mandible, and buccolingual expansion is there, and there is radio opacity as well as mixed radiolucency and locular appearance, very mixed appearance, giving the suspicion that it could be an ossifying fibroma. So this is another image, another picture of the same ossifying fibroma, which when actually clinically, if you look at it, it could have a peripheral component, and which is generally called as peripheral ossifying fibroma, but a central ossifying or of ossifying fibroma can start in the bone and then extend to involve the gingiva or extend over the gingiva. So the differential diagnosis for on a radio, I'm specifically talking about radiographic differential diagnosis, would again be fibrous dysplasia, periapical cemental dysplasia, central giant cell granuloma. That means it's a reactive lesion which again looks more radiolucent, and in later stages only this ossifying fibroma appears more radio opaque. So depending on the stage which you're looking at the disease, if it's in early stage, then central giant cell granuloma, COC, that is calcifying ontogenic cyst, could be differential diagnosis. But if you're looking at a little matured stage, a later stage, then and more radio opaque in nature, then fibrous dysplasia, periapical cemental dysplasia, and CEOT, all of which are having calcified component, could be the differential diagnosis. This is a central giant cell granuloma. This is a reactive lesion. This is not a cyst. Here, this is an example of a young patient, which you can see that he's having a swelling in the left side of the anterior jaw region, somewhere around the canine premolar region. When you look at it clinically, intraorally, you will see that there is vestibular obliteration somewhere around the extending from 31, 32, 33, 34, 35. That's the vestibular obliteration that you can appreciate. And this is the mandibular cross-sectional occlusal view, which is showing you radiolucency and enlargement of the bone as well. And the panoramic radiograph also shows you a large radiolucent lesion which is having well-defined boundaries, looking cystic, but considering that it is appears to cross the midline, and it is in the premolar region. The center of the lesion is in the premolar region. The first thing that you should suspect is a central giant cell granuloma. Remember, this is virtually one of the only radiolucencies in the jaws which appears anterior to the premolar region and tends to cross the midline. So that's the very important thing that you need to remember about central giant cell granuloma. Again, not a very rare lesion. It can be cured, and it is a reactive lesion, easily treatable. Cherubism, I've just included this. It's not a very common disease, but definitely you'll see multiple multilocular lesions. Teeth are all floating in the air, but the lesion is not soft in consistency. When you palpate, the cheeks would be bony. Recontouring of the bone is the only method of treating this patient. Of course, there are other treatment plans that have been proposed, but success in treatment is quite less. And then you see that the image of this patient from how it was in A, where it looks very radiolucent, and then it's gone to B, where it is C, where it is quite radio opaque. So that could be different stages of the disease, and the disease is progressing. Paget's disease, also called as osteitis deformans, it's a skeletal disorder involving osteoclasts, resulting in abnormal deposition and resorption of the bone. Now, what we remember when we think of Paget's disease, what we remember is this classical cotton wool-like appearance. So we have two images here of the skull, which show you, in the first image is a geographic osteolytic lesion, which is also called as osteoporosis circumscripta, and also pathognomonic for Paget's disease. That means it also starts like a radiolucency, here in this case involving the skull bone. Whereas more advanced stages, the disease becomes more radio opaque and has a cotton wool like appearance, patchy radio opacities, which looks like cotton, and that's the reason why the term cotton wool like appearance. And this is Paget's disease, also called as osteitis deformans. That was about the bone disorders and fibro-osseous lesions. Now I'm moving on to systemic diseases which manifest in the jaws. Now, when we're talking about systemic diseases, it's a whole huge spectrum of diseases. You could literally talk about the entire, worldly possible diseases which fall into this spectrum. But there's something very important that you need to remember. Based on the radiographic characteristics alone, it is not possible, virtually very, very difficult to determine the underlying disease. So radiograph only acts as an adjunct. So the general changes which can happen when you are suspecting the underlying disease and there is change in the bone pattern in the jaw is a change in size and shape of the bone, a change in number, size and orientation of trabeculae, altered thickness and density of cortical structures, and increase or decrease in overall bone density. So if you're seeing any of these changes in the bone, then you should suspect that probably there is a systemic disease. Having said that, it is again very difficult, or it is not possible to tell you which systemic disease manifesting in the jaws. So just by looking at the radiograph, it's impossible to say, yes, this patient looks like he's having diabetes. It's very difficult. You can only suspect that it's probably, suggestive of diabetes, for example. So let's look at some common diseases and their radiographic changes or manifestations which we see in the jaws. The first example is hyperparathyroidism, also called as brown tumor. Now the name brown comes not because of somebody's name, but because of the appearance of the disease, or the bone, which I will tell you in the next coming slides. There is increased circulating parathyroid hormone, increased bone remodeling happening, increased mobilization of calcium from the skeleton, and increased serum calcium levels. So what is happening is the calcium from the bone is getting deposited in the serum or in the blood. So that's why when you check the blood, the calcium levels are high, but the bone appears radiolucent because you've taken away the calcium from the bone. So this is what happens in hyperparathyroidism, because the parathyroid hormone is not able to do its job. Like bone defects, or you could have even salt and pepper like appearance of the skull. Hyperpituitarism, it leads to gigantism and acromegaly. You're seeing this an example. I think this is from a picture from a museum which shows you the size of a person who's having acromegaly, and the jaw size is larger. The size in the picture, the circle is pointing towards the larger size of sella turcica as well. Rickets and osteomalacia. What happens in this disease is there is inadequate serum and extracellular levels of calcium and phosphate. There is a defect in the normal activity of metabolites of vitamin D, especially 1,2,5-hydroxycholecalciferol, and which is required for resorption of calcium in the intestine. So in rickets there is hypoplasia, hypocalcification of teeth. which occurs in children. And in osteomalacia, it does not alter the teeth because development of teeth has already happened before the onset of the disease. So rickets is seen in children and osteomalacia is seen in adults. Now this is rickety legs. Look at the bow-shaped legs that you're seeing in this child. And of course there are a lot more manifestations. You would have read in general medicine about manifestation of ribs, the pigeon chest, etc. And then here you can see in this image which is showing you teeth, is that there is a generalized radiolucent appearance of the bone, and the teeth also appear very thinned out. Osteopetrosis is Albers-Schonberg syndrome, also called as marble bone disease. It is a rare inherited disorder of the bone that results from defect in the differentiation and function of the osteoclasts. Abnormal formation of the primary skeleton and a generalized increase in bone mass occurs. So that's why you could see in this images, the radiograph, it looks very, very radio opaque. The failure of normal bone remodeling results in dense but yet fragile bones that are susceptible to fracture and infection. That's why this dense appearance of the bone on radiograph gives it the name of marble bone disease. Sickle cell anemia and thalassemia. These are again blood disorders where both of them are type of anemias which are having the red blood cells have difficulty in carrying oxygen, and the appearance that you see on the skull here, the white arrow marks are pointing out towards something called as hair on end appearance. And in the mandibular anterior radiograph that you see here, there is widening of the trabecular pattern, or trabeculae, the bone marrow spaces are larger than usual. And also in the skull CT image you're seeing the dura is very, very thick. This is called as hair on end appearance. So that is about systemic diseases. Like I told you, one important thing to remember is it can only give you a guidance to what the disease could be. You will still have to do blood investigations or perhaps other health checks and history taking to correlate it with the radiographic finding in case it is an incidental finding. And these general bone findings do improve with the improvement of the disease itself. Next is ectopic calcifications. Some examples, this is a silolith. This image is a cross-sectional mandibular occlusal view which is showing you radio opacities, and the diffuse radio opaque shadow that you're seeing is that of the tongue, and it is superimposed by radio opaque, two different radio opacities not attached to each other. So probably these radio opacities are in the proximal part of the salivary duct. And which duct is it? In this region it has to be the Wharton's duct, which is the submandibular salivary gland duct. So if you notice the position of the stones, you will be able to say that it is closer to the premolars, and hence it is not the gland, but the stones are in the duct. That's something very, very important to notice in this radiograph. So the gland would be much posteriorly placed closer to the third molar region, which this radiograph is not imaging at all. So the stones which you're seeing here, or the siloliths, are actually in the duct. This example of carotid artery calcification, these are also ectopic calcifications. On a routine panoramic radiograph, these arrow marks are pointing out towards calcification seen in the carotid artery. This could indicate that probably the patient is suffering from atherosclerosis and may need further investigations, and could be a routine finding in patients who are above 50-60-year-olds, where you're seeing excessive amount of calcification in the carotid artery region. Next, we're going on to paranasal sinuses. The radiographs maxillary and other nasal sinuses, and sinuses are very clearly imaged on radiographs. And this is, for example, the picture of a maxillary sinusitis radiograph. In this image, you will see that this is a paranasal sinus view, where you are seeing that the left sinus appears normal, whereas the right sinus is showing you fluid level, air and fluid level. So that is how you're seeing that the fluid meniscus is very clearly appreciated, but it's not always that you see such a nice clear appearance. Sometimes this could be missed, and early sinusitis may not manifest with such nice radiographic findings. So that's the yellow part is the contour of the maxillary sinus, and the green arrow is pointing towards the air fluid level. So this is an example of maxillary sinusitis. This radio opacity which you're seeing is mimicking soft tissue, and the green arrow mark is pointing towards mucus retention phenomenon. You will see the dome shape appearance. So yes, mucoceles not only occur in the soft tissue in the oral cavity, but can also occur in the lining of the maxillary sinus. So they are called as mucus retention phenomenon, and they can be treated, and sometimes the patient can manifest with stuffy nose and other symptoms of the sinusitis like symptoms. This is an example of an odontogenic cyst arising in the maxilla but pushing the teeth into the maxillary sinus. So both the premolar and the canine, which have not erupted, and there's a retained canine which you can see here, deciduous canine, have pushed the teeth. They've got pushed because of the cystic content into the maxillary sinus, and you can see the image of the patient here with a enlarged cheek on one side. A trauma will only be covering it very minimally. Rest of it will be covered when you go to year 5 in much more detail. So this is just an introduction to how radiographs can be used to appreciate or can be used to manage cases of trauma. So we start off with simple things like concussion, luxation and subluxation. These are images seen in the order. Number 1 is concussion, where you can see ill-defined radiolucency with the teeth are pushed into the socket, and can lead to bone damage and bone changes, which is called as concussion. And you will see that probably this radiograph is taken few days after, a few months after the trauma, and then one of the central incisors is showing internal resorption. Then you have the middle radiograph, which is showing you white arrow mark pointing towards a tooth with widened PDL. Now, if you were not given the history for this patient and just asked to interpret this, you would have probably interpreted this as chronic apical periodontitis or a periapical granuloma, and you would be right. But having said that, if you were given this history of this patient, that this patient had trauma, and you're taking a radiograph just immediately after the trauma or day after the trauma, and you see the teeth are mobile in the socket, this is luxation, where the tooth has been displaced out of its socket but not entirely come out. So this is subluxation, whereas luxation seen on the extreme left side of the slide is a little more severe, where the tooth is actually displaced more than you can see that it has come out of the socket and displaced, leaving about 3 or 4 mm of the socket empty. So subluxation and luxation, the tooth is mobile but still in the socket, and if it is not too late, the tooth can sometimes be pushed back into the socket, and it can be retained. These are fractures. Of course, radiographs show you fractures very nicely. Horizontal fractures are depicted very clearly on simple intraoral radiographs. These are images of teeth which are fractured at the middle third or the apical third of the root, and you can clearly see the fracture line crossing halfway through or full way through the root. When it comes to vertical fractures, sometimes they cannot be appreciated. For example, on this radiograph which you're seeing here on the left side, the vertical fractures extending along the root canal, and sometimes can be mistaken, and you wouldn't really realize till which part of the root is the fracture extending to. So when you have a situation like this, the best solution would be to take a shift radiograph. The technique that you use in SLOB, slob, or shift the radiograph, take the angulation, and you'll be able to appreciate the entire vertical extension of the fracture line. So again, this is a bridge which is showing a fracture of the tooth here, and vertical fractures have poorer prognosis. It's very difficult to save the tooth, so the teeth are best extracted, because it's difficult to realize or exactly point out or even reach the extent of vertical fracture. Mandibular fractures, there's a huge classification, and it's a huge topic in itself, but I'm just going to show you some very simple radiographs which are showing you mandibular fractures, which could be seen with the pink, yellow and the red arrow marks pointed here. This is one particular case which is showing you fracture in multiple areas, 2 cases in fact, A and B, where the fracture line is extending all the way from the crest of the bone to the lower border of the mandible. So fractures which are there and a tooth is involved generally become unfavorable fractures, and it means difficult to treat those cases, but yet fractures can be treated in the surgery department. Right, there's some more examples. This is complex fracture, multiple fractures which has even left a small triangular island-like region of bone suspended in the fractured area. So this kind of complex fractures are more difficult to treat than the simple complete fractures. Again, these are CT images showing you fractures of the dentoalveolar fractures as well as fracture of the mandibular body. This is just an image to show you if there's a condylar fracture, then depending on how the muscle movement is and where the dislocation of the fragments takes place, the prognosis or ease of treatment is also depending on that. Condylar fractures, this is a reverse down view showing the condylar fractures. On one side, left side, white arrow marks are pointing out towards the fracture of the neck of the condyle, and on the right side is pointing out towards the angle of the body, angle of mandible fracture. So this is a reverse down radiograph. Maxillary fractures, when talk maxillary fractures are generally more complicated than mandibular fractures. Yes, the reason being because maxilla is a more complicated bone with a lot more structures in there. So this is an example of a blowout fracture of the orbit, which is the radiograph taken here is a PNS view, and you can see that the right side of the orbital floor is showing you fractured signs of fracture, and even the lateral wall of the orbit also there are breach in the continuity of the radiopaque line, which shows you that there is signs of fracture. Now this is an interesting radiograph. It's called as a jug-handle view. We've read this in special imaging or advanced imaging, where we've discussed that the submentovertex view, when reduced exposure is given, it is called as a jug-handle view. So essentially this is a submentovertex view, just that the rest of the area is bloomed out and only what you're seeing is the zygomatic arch. So if you observe on the left side, the zygomatic arch is flattened out, whereas on the right side you can clearly see the right side very clearly. So that's the handle of the jug which we're talking about, a jug's handle. So that's why it's called as a jug handle view. So this is an excellent radiograph to view zygomatic arch fractures alone, because the zygoma is a bone, that is your cheekbone, which is protruding out, and it can be visualized in this position. But one thing important to remember here is that if the patient is also having neck problem or problems in the neck bone, you're suspecting a bone fracture somewhere in the neck, it's not advisable to take this radiograph, because for this radiograph the patient will have to bend down completely, and the x-rays will have to be passed from the along the axial plane of the patient. Now this is pathologic fracture. Now the term pathologic fracture is used when there is an existing cyst or a tumor and it extends to the a thinner part of the bone and ends up fracturing the bone. So the green arrow marks are actually pointing out towards fracture lines extending from the cyst to the lower border of the mandible and ending up fracturing the lower border of the mandible. So this is called as a pathological fracture. That means an existing lesion extending to a bone, and because of the extension of the lesion it causes fracture of the bone. So the term used is pathologic fracture. So that brings us to the end of this chapter. We've covered various topics from the entire radiology textbook, and literally half of the radiology textbook, that is interpretation of diseases, is covered in these 3 chapters. I would recommend that please go back and do reading, compare the what I have laid out in the slides to what is there in the textbook. The textbook definitely gives you more information and more details of information. Should you have any doubts, please come back and ask me. I'll be more than happy to clarify your doubts. Okay, that's the end. Thank you.